In this lesson, we're going to be reviewing dementias. We'll go over what dementia is, broadly speaking, and then we'll learn about 3 common types of dementias. Dementias, or major neurocognitive disorder as it's called in the DSM, is diagnosed based on very specific criteria. These are evidence of significant cognitive decline from previous levels in one or more cognitive domains, and we'll typically look at that through informant reports, such as caregivers, and neuropsych testing. These deficits must interfere with an individual's ability to be independent, so things like driving, managing finances, being able to take their own medications are some examples of that. These symptoms are not exclusive to delirium, and they are not attributable to a psychological disorder like schizophrenia or depression. That's not to say that depression and other symptoms aren't present. They're actually very common in dementias, but they're not the primary cause for these disturbances and this decline. Dementia is a chronic or persistent disorder of the mental processes caused by brain disease or injury and marked by things like memory disorders, personality changes, impaired reasoning, etc. But it's really important to recognize that dementia is an umbrella term. So there are different types of dementias, and each of these different types may present with different symptoms and different patterns of progression. You can see over here to the right our little umbrella with several different types of dementias under it. We're going to be going over 3 today: Alzheimer's disease, dementia with Lewy bodies, and frontotemporal dementia, but there are others seen in pink, and beyond these, there are also other types of dementias as well. Alzheimer's disease is one of the most common dementia types, and it's also generally one of the most widely known and recognized. Generally, it impacts adults aged 65 and older, although it has been diagnosed in adults as young as 30. Only about 5% of Alzheimer's cases occur in adults under 65, and those cases are typically related to specific genetic risk factors that run in families. Alzheimer's can only be confirmed in patients post-mortem, but we can diagnose possible or probable Alzheimer's based on specific criteria in living adults. To diagnose, we must see a gradual decline in functioning over time. We must also see memory impairments, in addition to deficits in 2 other domains, like language or executive functioning, for example. This disease is associated with amyloid plaques and neurofibrillary tangles that build up in the brain, although we won't go into detail about the specific pathophysiology in this lesson. This is, of course, all in addition to the specific criteria that we saw for dementias earlier. Common early symptoms in Alzheimer's disease may include memory loss that starts to affect job skills, semantic memory deficits, difficulty performing familiar tasks. Some individuals experience language problems, especially things like word finding, disorientation to time and place, poorer judgment, so perhaps falling for more scams, problems with abstract thinking, misplacing items, changes in mood or behavior, depression is particularly common, changes in personality, and general loss of initiative and motivation. But the primary features are really these deficits in episodic memory. Dementia with Lewy bodies looks a little different. It accounts for far fewer dementia diagnoses compared to Alzheimer's disease, only about 5%. It's typically diagnosed after age 60, although the rate of occurrence does increase with age, as with Alzheimer's disease. Like Alzheimer's disease, it also requires this gradual progression in order to diagnose over time, and it has several core features. So fluctuating cognition, some days may be better than others. Recurrent visual hallucinations that are typically non-threatening, very well-formed hallucinations. and Parkinsonian symptoms, so shuffling gait, flat affect, symptoms that we would associate with Parkinson's disease. In addition to suggestive features, like REM sleep behavior disorder, which is acting out your dreams, and severe neuroleptic sensitivity. The pathophysiology involved is this buildup of Lewy bodies throughout the brain. Again, we won't go into the specific pathophysiology as part of this video. And although these common early symptoms may be present in other types of dementias once you get into the later phases of those dementias, they're very common early on in Lewy body dementia specifically. You'll also typically see concerns with attention and visuospatial functioning on testing as very common features. And one important thing to note, especially in the context of these visual hallucinations, is that they're very different from the hallucinations that you'd see in something like schizophrenia. And in fact, when individuals are given specific antipsychotic medication in Lewy body dementia, you can actually see a worsening of symptoms. The last type of dementia that we're going to go over in this lesson is frontotemporal dementia, or FTD, which accounts for about 5 to 10% of diagnosed dementia cases. It's typically an earlier onset dementia, so it's most commonly diagnosed when individuals are between 45 and 65 years of age, although it can happen younger or older. Again, we would expect to see a gradual progression over time, evidence for an associated pattern of decline within variants, and I'll go into what those variants look like. But you'll typically see relative sparing of learning and memory, as well as in perceptual motor functioning in those early stages. So relative sparing of areas that we might associate with Alzheimer's or dementia with Lewy bodies. And the pathophysiology involved is degeneration in the frontal and temporal lobes in the brain. Very easy to remember given the name of the dementia, frontotemporal dementia. And it's caused primarily by phosphorylated tau. Again, we won't go more than that into the actual pathophysiology. And as I mentioned, there are these different variants, and the actual patterns of progression that we're going to see depend on which variant an individual has. So frontotemporal dementia in some ways can also look a bit like an umbrella in itself. And these main variants are the behavioral variant, the language variant, and the motor variant. The common early symptoms that you're going to see in FTD are really going to be dependent on the variant at play that you're seeing. So the behavioral variant, we would expect early symptoms to include things like personality changes, disinhibited behavior, oftentimes inappropriate behavior, apathy, loss of sympathy or empathy, and dietary changes. So, for example, an individual may have a sudden increase for sweet foods or start putting things in their mouth that aren't food at all. In the language variant, those early symptoms are going to look different. The language variant is also known as primary progressive aphasia, and these first symptoms are generally impairments in language. And PPAs, primary progressive aphasias, are broken down into several other subtypes, and these language deficits may look like deficits in language comprehension, use of grammar and syntax, deficits in semantic memory and word-finding ability, etc. Lastly, we have the motor variant, and this is again broken down into different subtypes. And generally, you're going to expect to see motor impairments as this primary early symptom. This may also include, though, things like blurry vision and alien limb syndrome. And alien limb syndrome is an interesting one in which the limbs, like the hands, for example, move outside of conscious intent. So as if your hand or your leg or your limbs are alien and separate from you. Now that we've reviewed some common dementias, we can discuss the role of neuropsychology and neuropsychological assessment. Often, patients present for an assessment with concerns of dementia. They may be referred by another provider, such as a neurologist, and it's a neuropsychologist's job to determine 1, if there's cognitive decline present, 2, what the pattern of that decline is, and 3, what might account for that decline and or the perceived decline if no actual decline is present. Our assessments can reveal cognitive decline in 2 key ways. If an individual has had a previous assessment, a neuropsychologist can determine whether they've experienced decline since that previous assessment, comparing the individual to themselves. However, most people don't come in with a previous assessment already done. One way that a neuropsychologist accounts for this is by comparing patients' scores on an assessment to scores from healthy populations, usually matched to age and other relevant demographic factors. Neuropsychologists then use the patterns on testing, behavioral observations of the patient, and information from an interview with the patient to determine if a dementing process is present and which, if any, the pattern most resembles. So, for example, Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. This can provide diagnostic clarity to the referring provider and other practitioners, as well as to the patient themselves. Neuropsychologists generally provide an in-depth feedback session where they review the results, diagnostic impressions, and recommendations. These specific recommendations may be to address modifiable factors, such as increasing exercise, improving diet, and changing other factors that have been shown to improve health and slow decline, although other recommendations may be about ways to manage existing decline and expected decline. Those recommendations may be something to improve an individual's functional memory, for example, if they're experiencing memory decline, such as suggesting a memory notebook, or they may be more end-of-life recommendations, such as setting up a power of attorney or establishing a will, things that are important to consider in the context of dementias. Neuropsychologists are trained as clinical psychologists and may also be able to provide brief therapy to help individuals or caregivers cope with the diagnosis, provide further psychoeducation, or additional services beyond just the assessment, although the specific role varies from practice to practice and from provider to provider. There are a few final notes I want to leave you with before we end this lesson. The first is a reminder that these are not the only types of dementias. These are just common subtypes that we often discuss in neuropsychology. Second, dementias don't always fit neatly into boxes. Individuals can have symptoms of multiple dementias and can even present with the pathophysiology of multiple dementias when we look at their brains. Oftentimes in clinical work, things aren't always as easy to parse apart as we make it seem in these kinds of lessons. And finally, there are many risk factors at play when we're talking about the development of dementias. Lifestyle factors can serve as both protective factors or even risk factors. Things like diet, exercise, education, and even what you do in your leisure time can all play a role in whether or not you'll go on to develop dementia later in life. There are also genetic factors. Some of these genetic factors can be associated with a 100% risk of eventually developing dementia, such as in the case of Huntington's disease, and other genetic factors can also serve as a risk factor with no such guarantee. And finally, there are other factors. For example, there's a growing literature that shows that traumatic brain injury may serve as a risk factor for the development of certain types of dementias later in life, and certain health conditions like diabetes and heart disease can also increase an individual's risk later in life as well. In neuropsychology, it's important to look at modifiable factors, those that we can control, and encourage individuals to make changes where they can to try and maintain healthy cognitive functioning as long as possible.